Greetings, everybody. It's a great pleasure to be back at Interest, and I'm happy to be here in 2021 when it's virtual, discussing a very important topic. Our topic today is the elimination of HIV in children. And in my talk, I'll be focusing on status reports. So where are we? Where have we reached? I'll be identifying specific gaps that we see in our programs and offering potential solutions. So the prevention of HIV in children is one of the greatest successes we have had as an HIV community, starting from the proof of concept study, the 076 study in 1994, that was able to demonstrate that you could avert transmission by up to 2/3. Riding on this success, the scientific community continued to work on making the regimens more feasible to implement in resource-limited settings, while enhancing their efficacy to get the transmission rates much lower than the benchmark 2/3. And then finally, we also worked on simplifying the regimens so that the mothers would find it easy to take the medication, and the healthcare providers would find it easy to deliver the interventions. But the biggest game changer that pushed us to really consider that we could eliminate mother-child transmission was when we moved to the test and treat all pregnant women, the B+ regimen pioneered in Malawi. This was a scalable, feasible regimen that made it possible for healthcare workers to deliver interventions at the lowest level, and that really showed us that there was a path to elimination. Riding on this optimism, the global community set very ambitious targets, with the aim being to eliminate mother-child transmission as a public health threat by 2020. And our goals were to reach and sustain 95% of pregnant women living with HIV on long-life treatment, and also to eliminate new infections annually to less than 20,000 by 2020. In anticipation of success, the WHO set benchmarks for validation, where any country wanting to be validated as having eliminated HIV needed to have a population case rate of new pediatric HIV infections of less than 50 per 100,000 live births. And in addition, they needed to have HIV mother-to-child transmission rates of less than 5% if the population was a breastfeeding population, or less than 2% in non-breastfeeding populations. These were the benchmarks for success that we were looking forward to. But recognizing that high-burden countries would take longer to achieve these benchmarks, to achieve validation, a three-tier process was put in place that recognized each step, each victory along the way. The three-tier process recognized increase in coverage, so starting with the bronze at 90%, heading towards gold at a 95% coverage. It also talked to the issue of case rate, starting with a benchmark of bronze at 750 per 100,000 cases, and aiming to go to less than 250,000 per 100,000 for gold. So each step was to be acknowledged, and each step was to be validated: bronze, silver, and gold. And the interventions were, of course, to have been done at scale, at population level. The interventions were to also have been done in a way that was consistent with protecting human rights and ensuring gender equality and the engagement of civil society. These were our benchmarks to encourage countries along the way. So let's reflect on where we are against those benchmarks. We see that by 2020, we have attained a coverage of 85%, which is good, but is inadequate because our benchmark for this year was 95% coverage. In terms of the number of new infections annually, this is where we are falling woefully short. Our benchmark, as you remember, is 20,000 per year. Last year, we were at 140,000 new infant infections, 7 times our benchmark. As you will also note, progress is stagnating. For the past 3 years, coverage rates have remained the same. Something is not working for us, and we need to unpack that. But all is not doom and gloom. If you look at the landscape, we can see that a number of countries, 15 countries and territories have already been validated. So there's still hope that we can actually validate globally. You see here the countries and the years in which they were validated. And we just note one thing of concern, is that of all these countries, none of them are in Sub-Saharan Africa, the region most impacted by the epidemic, the region with the highest burden. So yes, we can claim success, but yes, we are really not hitting the mark as far as Sub-Saharan Africa. So let's dig deeper. What is actually happening in Sub-Saharan Africa? I'm showing here 2 charts, one for Eastern Southern Africa and one for Western Central Africa. The Eastern Central Africa graph in green shows you that the coverage has been pretty high at 95% by 2020. But the mother-to-child transmission rates remain above the threshold of 5% and are actually only at 8% right now. So we need to unpack why transmission rates remain high despite the high coverage. In Western Central Africa, coverage rates are still below 80%, actually very low at 57%. And transmission rates are at 25 times the transmission rates, or 4 times the transmission rate benchmarks for elimination. So again, really distinct differences between the 2 regions, but none of the regions reaching the benchmarks that we want. Now, if you look deeper and try and find out, so which countries, where is most infections happening? We see here that the distribution of HIV new infections in Sub-Saharan Africa 80% occur in just 9 countries, the 9 countries listed here, with the top 5 countries being Nigeria, Mozambique, South Africa, United Republic of Tanzania, and the Democratic Republic of Congo. So if we're to make a difference, we really need to zero in on these 9 countries and see how to break the transmission rates and how to get the impact that we need in our programs. So how do we do this? What is going to make the difference is in our focus, is in our better understanding at the country level and at the sub-national levels. A tool that has been developed to help us do this is a tool, the stack by analysis tool, which is spectrum-based, developed by UNAIDS. And it allows us to look at the gaps and the missed opportunities that we see in pregnant women and to track that against the infant infections. So what I'm showing here is the global stack bar. On your left is the number of pregnant women living with HIV, and on your right are the child infections. Let's start first with the pregnant women living with HIV. The blue colors indicate where we've had success. These are the mothers who we've been able to reach with the interventions. The dark blue are mothers who started antiretroviral therapy before pregnancy, so excellent. The blue started therapy during pregnancy, early enough for the intervention to work effectively. And the lighter blue started late in therapy. So these are our successfully reached mothers. All other colors above that are missed opportunities. The gray show mothers who came on to treatment but dropped off therapy. So we're not able to retain them on therapy. The yellow are our abject failures. These are mothers who came to us, but we never gave them antiretroviral therapy. And then the orange are the mothers who got newly infected during pregnancy, and the bright red are the mothers that got newly infected during breastfeeding. The infant bar is color-coded in the same way, and you can see that most infant infections are occurring because mother did not receive ART, the bright yellow, followed by the fact that mothers are not being retained in care either during breastfeeding or during pregnancy. And then finally, the issue of incident infections, particularly during the breastfeeding period. These are the areas where we need to zero in. Now, similar analysis can be done at regional. So I'm showing slides, stack bars here for Sub-Saharan Africa, it's the first one on your left, East and Southern Africa is the second one, and West and Central Africa. And we're not going to go really deep, but at a glance, if you look at the bar to your extreme right, the West and Central Africa bar, what jumps at you is the bright yellow. Most women are not getting their ART. So if one game changer is to happen in West and Central Africa, it is start, test and treat majority of pregnant women to bridge that gap. When you look at East and Central Africa, when you look at East and Southern Africa, it is not as clear. It's a bit more complex, but we see that still there are mothers who are not getting treatment. But incident infections, particularly in the breastfeeding period, is a big issue, as well as dropping off care. So in East and Southern Africa, they need to really focus in on incident infection, retention in care, even as we try to reach those final numbers with the interventions. So let's look at a country stack bar just to show for illustrative purposes that these analyses can go right down to country level and even to subnational level. What I'm showing here is the stack bar for the Democratic Republic of Congo from last year. And again, you can see that the bright yellow, mother not receiving antiretroviral therapy during pregnancy and in breastfeeding, is the main cause of infections in children. So the program managers, the policymakers can actually see where to target the interventions. So as we do these analyses, they're not an end in themselves. We need to ask ourselves a number of questions. What changes do we need to make to our service delivery to ensure better delivery of ART for pregnant women? We need to ask ourselves who is missing and why. Is it the young women? Is it the women who are members of key population groups who are missing and why? And then we also need to ask ourselves, how can we better support mothers to stay in care and on ART during pregnancy and breastfeeding? Why are women dropping off? We have interventions for these things. We know that mentor mother programs work. We know that peer support works. We know that integration of services, HIV services into maternal child health services gives us better outcomes. We also need to ask ourselves, how do we strengthen primary prevention for pregnant women and their partners? We now know that their PrEP interventions, are we rolling them out in our PMTCT programs? We also know that self-testing is an important tool for getting partners in. Are we rolling them out in our programs? So in addition to the stack bar analysis, we need to do a lot of qualitative work and use other evidence within the country to better understand how to prioritize the interventions to the gaps that we have identified. So in summary, what I can say is that there's been significant but uneven progress in PMTCT coverage. Unfortunately, we have hit a plateau in all the regions. The coverage is flatlining. The impact of our programs as they are insufficient to reach our global targets, and we need to act urgently to tailor our responses to the gaps we see in access, to tailor our responses to the gaps we see in the quality of programs, to improve the testing with linkage, to improve retention in care, to improve adherence. These are the things we need to be focusing on. We no longer can have one size fits all. We no longer can have cut, paste. Each place will need to have solutions that are context specific, and countries need to do those analytics. We need to use our data very robustly to have this difference. So to enable countries to do this, UNICEF, UNAIDS and WHO came together and developed what we're calling the Last Mile to MTCT framework. It's a programmatic guidance that goes step by step to work with countries so that they're able to do the analytics using the stack by analysis, and then prioritize the interventions that are context-specific for their settings, either at the national, sub-national, or even at the facility level, to be able to make a difference. The guidance are available for countries to use, and that we're framing this guideline as our last push towards ending vertical transmission in mothers, ending vertical transmissions for children. This is our last push. This is why we're calling it the last mile. We're not at the last mile, but this approach will get us to the last mile. And so I'd like to end by thanking you all for listening. I'd like to thank my colleagues at UNICEF and my colleagues at WHO for helping me put together this presentation. Thank you very much.